Thank you, Dr. Chow, and it's great that you work with Nisha, and yeah, she's been a wonderful leader for us in building our program here at UCLA, and I really feel privileged to be a part of her team. And thank you so much for inviting me to be part of this discussion. Hopefully, this is helpful, and excited to hear the case, and hope I can chime in with some thoughts that are helpful and productive for the team. Um, I'll go ahead and get started. If anyone has questions along the way, feel free to raise your virtual hand, and I can pause too. I'll see if I can keep track of this. But I'm going to focus my talk on the long-term cardiovascular complications and COVID. I will say that there's still clearly a lot that we are learning, but as opposed to a few years ago when I give a similar presentation, at least now we know a lot more, and at least we have some experience as to what we're seeing, what we're seeing work, what we're seeing doesn't work. So I do think it's at least we have more information at this point in time. But as mentioned, I'm part of our long COVID program at UCLA. I was initially the only cardiologist for a while, but recently we've had an additional cardiologist join, Priscilla Hsu, and she was at UCSF for a long period, where they clearly also have a very strong long COVID clinical and research program. So lucky to have her as part of the team. So brief outline for this talk, I'll go through long-term complications of COVID. We'll discuss long COVID and how we can distinguish some subcategories of long COVID, looking for symptoms that are suggestive of cardiovascular disease, or symptoms that are mainly cardiovascular in nature, but not a manifestation of underlying cardiovascular disease. We'll walk you through my diagnostic approach in these cases and some management strategies, and we'll touch on some ongoing challenges, at this stage. So no financial disclosures. I'll start off with a case. So a young man I saw early in the pandemic who has no prior medical history, and he was a military recruit. And he had a mild case of COVID in late 2020 and a reinfection in early 2021. Now, with the reinfection, he had more symptoms, and these included fatigue, palpitations, and he actually syncopized during a training workout. He had a workup that included an ECG, which showed a couple of premature ventricular contractions, or PVCs. He had an echo that was normal, and cardiac biomarkers were normal, as was CRP. But because of his syncopal episodes during the workout, he underwent more extensive testing that included a cardiac MRI. And this cardiac MRI did show a small area of late gadolinium enhancement, or LGE, which is suggestive of scarring in his left ventricle. And these findings were suggestive of the presence of myocarditis in this young military recruit. So I'll go back to this case a little bit later. But what do we know about how COVID can impact cardiovascular risk? A huge, a leading group in this area has been out of the VA in St. Louis. And it's Ziad Al-Ali, who's really given us at least the most impressive early data about the longer term cardiovascular outcomes after a COVID infection. And looking at the VA healthcare system, at about 150,000 patients who were tested positive for COVID-19, and when they compared these against a large number of controls, both 5 million contemporary controls, almost 6 million historical controls, and looked at the diagnoses of these veterans at 1 year after this infection. They found that being diagnosed with COVID was associated with a twofold increased risk of being diagnosed with cardiovascular disease in that subsequent year. This risk did increase with the severity of the initial COVID infection. So those who were hospitalized with COVID had a much higher risk of developing incident cardiovascular disease, such as stroke, abnormal heart rhythms, ischemic heart disease. So the concern was initial disease severity, increased risk even further. And notably, this risk was present in all subgroups. Even in the younger veterans, they saw that infection was associated with increased risk. Now, they've had subsequent studies looking at this follow-up even at 2 years after diagnosis. And while in general, they did see that the risk of cardiovascular diagnoses did steadily start to decrease, But still, for some conditions, the risk was still present at 2 years. And primarily, the risk was still present in those who were hospitalized with their initial COVID infection. And for the most part, those who were non-hospitalized ended up having kind of a normalization of their risk at 2 years of follow-up. Now, notably, these studies began in the pre-vaccination era. So again, most likely we do think that vaccination helps reduce the risk of developing these longer term complications. And I'm sure data are forthcoming as to how that has impacted these findings. Well, some of the initial thoughts about these large studies, again, published in some of our biggest journals like Nature Medicine, was that this was a veteran population. These findings have been reproduced in multiple different large healthcare systems, more representative of the general population. So I think this is something that we now know is clearly associated with the COVID infection. So what are the potential mechanisms of cardiovascular risk after a COVID infection? I'll say that at this point, we're still not quite sure, but I think what we do have some evidence of is that it seems to promote a prothrombotic state. So this can lead to large thromboses, even microthromboses, or I think colloquially we call them microclots. Mechanisms not clearly known, but I think this is something that there has been more data to support this potential mechanism. Endothelial dysfunction leading to abnormal vascular stiffness is a possibility, and also systemic inflammation, and this may be associated with the increased risk of myocardial and pericardial injury. One thing that we are pretty sure is not as likely these days is direct invasion of the virus into the heart. I think early on in the pandemic, we were concerned that the virus of SARS-CoV-2 is directly invading cardiomyocytes, and this is why we're seeing cases of viral myocarditis. There were some very early studies that showed images of the viral particles of the virus present within the cardiomyocytes, but I think now with larger data sets, we show that this is, we see that this is incredibly rare. So direct myocardial invasion is less likely, but again, we'd still see the evidence of myocardial and pericardial inflammation. One of the early studies that got a lot of attention was this one in Nature Medicine back in 2020, where they performed cardiac MRIs of people who had mild cases of COVID-19. So in 350 patients with mild cases, when they did MRIs on all of these patients, they found that 78% of this population had an abnormal cardiac MRI. And this is at, within 100 days, they had the MRI done within 1 year after their initial infection. So who are more likely to have these cardiac symptoms? So these were, so what were the symptoms associated with these findings? So most of these patients did have persistent cardiac symptoms like dyspnea, palpitations, chest pain, and they were more likely to have symptoms if they were female or if they had an abnormal baseline cardiac MR. Now, notably, the presence of late gadolinium enhancement, this LGE that you see at the bottom right, suggestive of SCAR, was present in almost 40% of the patients who had a mild case of COVID versus 7% in a control group. When you look at the pericardium, almost half of the patients who had mild COVID had evidence of pericardial enhancements suggestive of inflammation of the pericardium or pericarditis versus 16% in the control group. And so the presence of pericardial enhancement was more common in those people who had persistent symptoms. So this raised concern about the prevalence of myocardial and pericardial inflammation in people who had COVID, even mild cases of COVID. Another study that gained a lot of attention was this one that came out about a year and a half ago now, maybe 2 years ago now, actually, in Nature Cardiovascular Research, where they looked at autopsy specimens of people who had been infected with SARS-CoV-2. And they looked at their coronary arteries. And what they found was in a number of these patients, the patients who had atherosclerotic plaque within the coronary arteries, they were able to find the presence of SARS-CoV-2 RNA and protein in the plaque itself. So spike protein and SARS-CoV-2 were identified in coronary atherosclerotic plaque, and their conclusion was that their data establishes that the virus infects coronary vessels. So as I mentioned before, the risk of ischemic cardiovascular events seems to increase in the year to 2 years after COVID infection. And so this study raised a concern that there could be presence of the virus within atherosclerotic plaque, and could this lead to plaque inflammation, plaque rupture, which can lead to the ischemic events that we've seen. So, so this was an important study and a concerning study. So those are some of the mechanisms whereby infection can lead to cardiovascular symptoms long term. But what are the symptoms that we see in long COVID? Well, as you know, this group, I'm sure you've seen a lot of long COVID by now, but symptoms can range from all over the body. If you focus on the cardiovascular symptoms, these include tachycardia, palpitations, chest pain, dyspnea, exercise intolerance. One thing I see pretty commonly, I think probably the most common symptoms in my patient cohort are these two. More constitutional symptoms of fatigue and post-exertional malaise, which I'll talk a little bit more about later in this talk. But in terms of the cardiovascular symptoms, you know, how do we approach these? Well, this is the approach that we have in our program. So on an initial intake visit, it's important for us just to get a sense of their initial severity of COVID-19. I want to know if they were hospitalized with COVID, because that does make me more concerned about poorer outcomes, as I mentioned earlier in this talk. Also think it's important to ensure we're evaluating orthostatic symptoms and orthostatic vitals on the intake visit, because these are some of the more common symptoms I see in my long COVID cardiology clinic. One test I perform on every initial visit is an active stand test, and I'll talk about that on the next slide. But in terms of laboratory testing, imaging, additional testing we do, initially we'll do a screen with an echo, and often we'll just get a baseline troponin and ECG. In addition to basic labs, I often will be ordering an ambulatory ECG, since palpitations are one of the more common symptoms I see. I just want to ensure that we're not seeing any abnormal heart rhythms, and do some chest imaging and also lung function testing. What am I trying to do with this workup? Effectively, I'm trying to diagnose the presence or absence of objective cardiovascular disease. And if these tests, this workup is abnormal, then I make the diagnosis of post-acute sequelae of COVID-19 with cardiovascular disease. And these diseases include inflammatory heart disease, ischemic heart disease, cardiomyopathy, arrhythmias. So you can diagnose these based on the initial testing done in our program. And if these tests, I'll say more often than not, they end up being normal, and we can't find any objective evidence of disease, then here we label this as a pass with cardiovascular symptoms, because the symptoms are still present, but we just haven't been able to identify any objective evidence of disease. So in terms of the orthostatic testing we do, this is the active stand test, or the NASA lean test. Basically, it's orthostatic vitals, but making sure we extend the measurements up to 10 minutes after going from the supine to standing position. And you know, it is important to carry this testing out I would say at least 5 minutes, ideally 10 minutes, because sometimes we don't see changes until that 5 to 10 minute mark. what you're trying to note here is, in addition to changes in blood pressure and heart rate, you just want to get a sense of whether or not the patient becomes symptomatic upon standing, which I think is important to document. So in terms of when to refer to cardiologists, I think most of the folks in the crowd here today are not cardiologists, who are maybe primary care clinicians, are kind of the first line seeing these patients. My recommendations for when to refer to cardiology stem from the American College of Cardiology statement on this topic. But this includes the presence of abnormal cardiac test results, if someone has known cardiovascular disease and they're presenting with new or worsening symptoms, if they have documented evidence of cardiac complications during their initial COVID-19 infection, or if they have persistent unexplained cardiopulmonary symptoms. So these would be very valid reasons for referring to a cardiologist for further management. Now, so patients who are diagnosed with cardiovascular disease should clearly have a cardiology consultation. And then as a cardiologist, what are we doing to manage these patients? For the most part, we don't have specific guidance that is uniquely tailored to COVID according to our guidelines. But I'll say, at least as a long COVID cardiologist, there are some disease entities or syndromes that I just feel like I've become a lot more comfortable managing, just because I'm seeing a lot of it. And particularly when it comes to inflammatory heart disease, important for the cardiologist to talk with the patient about exercise, and trying to keep exercise intensity to low intensity in the presence of acute inflammatory heart disease like myocarditis and pericarditis. In terms of treatments, what I found surprisingly effective, in addition to colchicine, which I use very frequently for these conditions, particularly for the pericarditis, in patients where I do see colchicine is helpful, I found dramatic benefit from the use of the anti-interleukin-1 agents, particularly rilonacept, also known as Arcalyst. So in patients where I'm suspicious of pericarditis, if the testing is clearly showing pericarditis, or case one of the young man with myocarditis, so he had the presence of a clear inflammatory heart disease based on his cardiac MRI. Now, what do we do if they don't have objective evidence of cardiovascular disease? So this complex kind of workflow diagram from the ACC statement. But if the results are normal, what we're left with is a patient who has cardiovascular symptoms. It's important we don't leave it at that. And unfortunately, I think too commonly in this patient population, if nothing objective is identified on testing, they often just get told, hey, nothing's wrong. You'll feel better with time. You just need to rest and get through this. I think it's really important we don't leave it at that. I think these are very real symptoms that are objectively causing decrements in their quality of life. So how do we manage these symptoms? How do we help patients through these often debilitating symptoms? So this is what I'll focus on over the next few minutes. This case is a young skier who, after not only initial COVID infection, but interestingly, after a second dose of a COVID vaccine, she developed severe orthostatic symptoms, ultimately became bedbound. Her cardiac MRI was normal, but she had autonomic testing that did show pronounced heart rate increase with going from the supine to standing position, and she was diagnosed with POTS. So, these orthostatic symptoms are one of the more common symptoms that we see in this population, at least the patients I see in my COVID cardiology clinic. So in addition to orthostatic intolerance and POTS, I see post-exertional malaise and exercise intolerance. Unfortunately, in long COVID, there's this downward spiral where the initial infection, we get told to stay at home, rest, but that bed rest can lead to pretty quick deconditioning. And the deconditioning can lead to a worsening of symptoms with exercise. And as symptoms worsen with exercise, this leads to more bed rest, which can lead to more deconditioning. And unfortunately, this downward spiral can propagate. Now, I think the challenging thing is this issue of post-exertional malaise, which honestly I did not really appreciate until the pandemic and dealing with long COVID patients. But the post-exertional malaise really limits their ability to recover from this infection. So what is post-exertional malaise? It's the worsening of symptoms following physical or mental exertion. There can be a delayed onset. This can occur 12 to even up to 48 hours after the activity. And this is just pronounced fatigue that can last for days, sometimes even weeks. I've had some patients say it lasted months. So importantly, PEM is not deconditioning. And oftentimes patients get told just to power through this fatigue and they just need to get their body back in shape. Unfortunately, patients who do that, I've seen they feel like they get significantly worse. And we have to be very cautious about how we counsel patients on exercise. I think there still clearly is a role for exercise in the rehabilitation and recovery from long COVID. But importantly, we need to not counsel on aggressive exercise, but really need to tailor the exercise towards what an individual patient can manage successfully. And very important to counsel on this concept of pacing lifestyle strategies where you really focus on energy conservation, not wanting to exceed one's energy levels with any given activity and to allow enough time for rest after any stressful activity. Orthostatic intolerance, just very quickly, this is when symptoms get worse upon standing, get better upon lying down. If it's associated with significant changes in blood pressure, this is called orthostatic hypotension. It's associated with a significant increase in heart rate, namely greater than 30 beats per minute. This is called postural orthostatic tachycardia syndrome, or POTS. So notably, POTS, the diagnosis of POTS means that there's also a diagnosis of orthostatic intolerance, but orthostatic intolerance does not always mean POTS, because again, for there to be a diagnosis of POTS, technically there has to be this 30-point increase in the heart rate upon standing. What are the symptoms that they can experience in POTS upon standing? In addition to the common symptoms that we think about, like palpitations and chest discomfort and shortness of breath, it can include other more vague symptoms like fatigue or nausea, and interestingly can include a lot of neurological symptoms, including the brain fog that is so common in patients with long COVID. So I do think POTS and orthostatic intolerance are a lot more common than we appreciate. I'll just go through these slides here. So is POTS autonomic dysfunction? We do think that the autonomic system, we often equate POTS with being equivalent to autonomic dysfunction. But notably in some early studies looking at patients with long COVID referred for dedicated autonomic testing, the presence of POTS was not too common. In about 20% of the patients referred for autonomic testing, they were diagnosed with POTS. Other studies showed some similar statistics for, again, roughly about 20% actually were diagnosed with POTS when they had full autonomic testing. So it is there. Maybe POTS itself is not as common as we think, but it is something that I do think is very important to at least do some testing, like an active stand test, to see if you can diagnose its presence. Because if it's there, I do think we have some treatment strategies that we have found to be effective. For me, I ensure that they know my 3x5 rule, which is 3 liters of fluid and 5 grams of sodium a day. And I want to make sure that they know these numbers. I want to make sure that in clinic, next time they come to see me, that they have a water bottle with them. And that makes me feel more confident that they're achieving the 3 liters per day. And also for 5 grams of sodium, not easy to do. They often are very familiar with the electrolyte powders that are commonly available now, like LMNT and Liquid IV, and know how much sodium is in each packet. Now, importantly, as I mentioned before, exercise has a role. in the recovery process, but again, it has to be really tailored to the patient. It's the protocol we provide to our patients is the Ben Levine graded exercise protocol. These days, there's a lot of stigma around exercise in long COVID, and I think this is because of how aggressively exercise was pushed early on. So you may encounter a lot of resistance with patients when you talk about exercise. So it's very important you approach this topic very delicately in patients and work with them to individualize a graded exercise program that will work for them. And this is just a schematic, just communicating the example of a very slow, gradual increase in the exercise intensity over weeks to months. And ideally, starting off, if they're very symptomatic, starting off with recumbent exercises like rowing or recumbent cycling. So it keeps their body from having to navigate the upright position. Effective medications for POTS are ones I include here. I tend to start off with beta blockers like propranolol. I will say I use ivabradine quite a bit in this population, namely if they are symptomatic from their palpitations upon standing. Ivabradine will do a really good job at slowing their heart rate down. Oftentimes, it's just very hard to get insurance to cover it. So usually they require not tolerating or failing a beta blocker. And then if there's presence of orthostatic hypotension, then I'm using medications like midodrine and fludrocortisone to help support the blood pressure. Now, lastly, exercise intolerance in long COVID, quite common, and this has been objectively assessed. Out of UCSF doing a meta-analysis on long COVID studies that incorporated CPET, they found that there was a decrease in VO2 max by about 5 mils per kg per minute in this meta-analysis. So objectively reduced tolerance, and they found in their studies that decondition is not the only explanation for this reduced exercise tolerance. I'll skip through this. So in summary, what we need to know about the long-term complications of COVID: the risk is real. It will vary by the demographic, risk factors, and importantly, the severity of the initial illness. And symptoms that are very important to know about and to be familiar with if you're seeing this population include post-exertional malaise and orthostatic intolerance, and important for us to evaluate for POTS, which we can easily do with an active stand test in our clinic, as this is seen in roughly 20% of people with long COVID. So I'd like to thank everyone, especially not only our long COVID program at UCLA, but also the patients in the long COVID community whom I've learned a ton from over these last 5 years. So thank you for your time. And now I'll turn the stage over to Dr. Chow.
Thank you so much. Oh, this is wonderful in learning so much from the cardiovascular complications. And so Morgan will pull up our slides in terms of what we have experienced here in Hawaii. And then perhaps we could even inform the group about some of the research that Melissa has done along with the long COVID group here in Hawaii. So Morgan, the next slide. I didn't. I don't want to spend too much time because I think having on the subsequent case to actually ask Dr. Hsu about what he wants to, what would be appropriate to help our client. But just in terms of the poll, the answer would be B. Which of the following is best describes the relationship of long COVID and cardiovascular disease? We know from what Dr. Hsu was just mentioning, patients with long COVID may experience persistent cardiovascular symptoms like chest pain, palpitations, and POTS way longer than the acute phases of acute COVID. People with respiratory symptoms will often have also cardiovascular issues, so it would not be wouldn't be C, in that it's not only limited to people with pre-existing conditions. We have many individuals in our long COVID that have issues with long COVID without any pre-existing heart conditions. And then one things that we've been learning more about long COVID is some of the associations of of not only inflammatory issues or viral persistence, but also possibility of risk of blood clot formation. So again, for the answer, it would be B. Next slide. Um, our colleagues in just the objectives of just learning more. Continue the next slide. One more. So our colleagues at Mount Sinai basically had just shown for the differences in long and acute COVID, and that there are ongoing cardiac pulmonary abnormalities, even in the controls where uh, and they're having abnormal PET scans and normal PET scans in individuals with long COVID, that they do have increased hormonal biomarker profiles. So that there are abnormal pro-inflammatory markers that exist months to years afterwards. And we're not sure where that will kind of increase the risk for heart failure, pulmonary hypertension, and valvular disease. And Dr. Su had mentioned about the increased risk for some of the like ischemic stroke, CHF, and um, uh, coronary heart disease, which he showed in one of his slides of increased relative risk. Next slide. And so this is just the slide of the overlap of acute and long COVID, and just to see that there are many possible mechanisms that could be attributed to some of the overlap as well as the long-term ramifications from increased risk for heart failure, increased onset of diabetes, hypertension, myocardial fibrosis that was mentioned before, and then the risk of sudden cardiac deaths is not fully materialized, but perhaps maybe in terms of some type of arrhythmias. So Melissa will kind of talk to us about some of the findings that we've seen here in Hawaii.
Next slide, please. Okay, thank you, Dr. Chow. So moving more into the mechanism of the long COVID onset, we're going to briefly discuss ACE2, the role of ACE2 in CVD and long COVID. So ACE2 is a key regulator in the renin-angiotensin system, or RAS, which is a hormonal network that controls blood pressure, fluid balance, and also vascular tone. So if you look at the top section of this figure in A, this illustrates the normal function of ACE2. So it begins with the secretion of angiotensinogen from the liver, which gets converted by renin, which is an enzyme released by the kidneys, into angiotensin 1 or Ang1. And then Ang1 then gets converted into Ang2 by ACE, which is also angiotensin converting enzyme, into Ang2. So Ang2 is a vasoconstrictor and also a pro-inflammatory peptide. So what ACE2 does is it sort of functions as a brake by converting Ang2 into angiotensin 1 through 7, which is protective. And this causes vasodilation, regulation of blood pressure, and it has an anti-inflammatory and antioxidant effect. So RAS can be impacted by SARS-CoV-2 because ACE2 is also the entry receptor for SARS-CoV-2. And if you look at the bottom portion of this figure, when SARS-CoV-2 binds to ACE2, this causes dysfunction of ACE2, and that prevents the conversion of Ang2 into the protective Ang1 through 7. And as a result of ACE2 disruption, this causes vasoconstriction, increased blood pressure, vessel injury leading to inflammation, uniform fibrosis, microclots, and ultimately into long COVID through the persistent microclots, uniform fibrosis, and sustained vessel injury and impaired oxygenation, which can have a multi-organ injury in relation to the heart for CVD, but also it can affect the brain and other organs too through ACE2 binding. So as we move on to the next slide, so this also further emphasizes the role of ACE2. So SARS-CoV-2 primarily enters the lungs by binding ACE2 receptors on alveolar epithelial cells. And if you look at the bottom left portion, it kind of reiterates what we previously saw. So the receptor binding domain of the spike protein binds into ACE2. And proteases, such as Temperis and Atom-17, facilitate spike protein priming and also ACE2 shedding. So the shedding causes also the dysfunction of ACE2. But the infection can also secrete pro-inflammatory cytokines at the top. You can see on the top portion here, which causes phagocytosis by macrophages, alveolar macrophages. And this causes the transport of the virus into blood vessels. And once transported into the bloodstream, the virus can infect ACE2 expressing cells in other organs, leading to multi-organ injuries, such as the heart in relation to CVD. Okay, next slide, please. So relative to ACE2 dysfunction, our group is interested in ACE2 autoantibodies in long COVID. And it can be explained, the production of ACE2 autoantibodies can be explained by the network hypothesis by Niels Jerne. So it is believed that the immune system is a self-regulating network of antibodies where in antigen, so in this case, SARS-CoV-2, induces the production of primary antibodies that bind onto the antigen. So if you look here, you can see the production of the antigen-specific antibody 1, we'll call it, and this is geared targeting SARS-CoV-2. But there's a variable portion in this antibody or the idiotypic region of antibody 1 that becomes also an antigen for a second antibody, which is the anti-idiotypic antibody in number 2. And this helps to regulate or terminate immune responses. So this is just to control the immune response to SARS-CoV-2. And that leads to the formation of these immune complexes and the downregulation of that first antibody specific to SARS-CoV-2. However, this antibody 2, or the anti-idiotypic antibody, can structurally resemble or mimic the original antigen epitope. So in this case, it would be the receptor binding domain of the spike protein. And if this is dysregulated, this can lead to autoimmunity. And you can see on the bottom here, mimicking the spike protein allows it to bind to ACE2, and that blocks the ACE2 activity, which was mentioned in the previous slides. So in long COVID, in relation to long COVID, a persistent anti-idiotypic or antibody 2 population targeting ACE2 could represent a maladaptive persistence of what is normally a transient immune regulatory step. And this is caused by molecular mimicry. So if we can click on the next slide. It can also, that's one explanation of how these autoantibodies can be formed. But as we previously mentioned, the binding of SARS-CoV-2 can lead to shedding of ACE2 and cause soluble ACE2, and that can also develop autoantibodies, and this is increased during infection. Next slide, please. So we developed a Luminex bead-based assay to measure these autoantibodies, in which a magnetic bead is coated with ACE2 to capture these ACE2 autoantibodies. Then in the second arrow, a fluorescently labeled antibody is then added to bind onto these ACE2 antibodies, and then a magnet is applied to isolate these beads with these complexes on there. And this can measure and determine antibody levels, so ACE2 antibody levels through this MagPix Luminex machine. Next slide, please. So in a preliminary, this is a very small preliminary study that we did. We measured ACE2 autoantibodies in 3 different groups: those with no history of COVID-19, those who have recovered from COVID-19, and those who had long COVID. And we found that although it's not significant, most likely because of the small sample size, there was a trend, though, for increased IgG ACE2 autoantibodies in the recovered and the long COVID groups. And it was just shown in IgG in comparison to IgM and also IgA autoantibodies. But this is expected due to the longer persistence of IgG compared to IgM, which is the first isotype produced. So it's very short-lived, along with IgG, which is longer-lived, a little bit longer-lived than IgM because it's class switched from IgG and also IgM. And it can also form immune complexes, but it's cleared a lot faster than IgG. And so the prevalence in long COVID is a lot less than IgG. And so our thought is that these IgG autoantibodies may likely cause these ACE2 imbalances. And we recently did, I had to submit these slides before we did further assays, but we recently did another assay measuring soluble ACE2 levels, and we found the reverse. We're finding the reverse trend where those with long COVID were having lower levels of ACE2, soluble ACE2 in the plasma. And this is most likely because it's in these immune complexes with these ACE2 autoantibodies. But further tests will need to be done. Okay, next slide, please. Oh, so another investigator in our group, Dr. Jawan Park, she is interested in neutrophil biomarkers. So in these same participants, she measured soluble cytokine levels and found significant levels of MMP9 and double-stranded DNA in the long COVID groups compared to the other groups, the no history and the recovered groups. These markers are associated with neutrophil extracellular traps, which is what she's interested in, or nets, which are web-like structures made of DNA, histones, and antimicrobial proteins that neutrophils release to kill microbes. And so this is protective in an acute infection, and these nets release MMP9 and also extracellular double-stranded DNA, which is what she's demonstrating here. But in relation to ACE2 autoantibodies, their presence, the presence of ACE2 autoantibodies can potentially trigger neutrophils and increase neutrophil nets, which release these MMP9s and double-stranded DNA. And this may provide some upstream information of what may be triggering these net formations. Next slide, please. So to summarize everything up until this point, long COVID presents new challenges for cardiovascular health in Hawaii, and the mechanism of cardiovascular disease in long COVID require further investigation. The effects of the RAS, or the renin-angiotensin system, in long COVID are also being investigated. Early recognition, monitoring, and tailored treatments are crucial, along with awareness and the need for support groups for long COVID. Further research is also needed to further understand the long-term impact of COVID-19 on heart health, especially here in Hawaii. Geographic isolation may limit access to specialized care, limited local data on the long-term cardiovascular impacts of COVID-19, longitudinal studies to track cardiovascular impact of long COVID in Hawaiian populations, and exploring ethnic and genetic factors and the susceptibility to heart disease post-COVID. And with our preliminary ACE2 autoantibody studies, the presence of these ACE2 autoantibodies in long COVID patients may contribute to persistent inflammation and endothelial dysfunction, along with neurological and cardiovascular disease. And our preliminary data found that elevated IgG autoantibodies in long COVID likely affects the enzymatic activity of ACE2, leading to increased Ang2 and decreased Ang1 through 7 due to defective ACE2. And also MMP9 and double-stranded DNA serve as promising markers for long COVID through their inflammatory contribution. So now I'll pass it back to Dr. Chow. I think he has a few case studies.
Yeah, so next slide. So a lot of the studies that the findings from Melissa were actually from our long COVID clinic. And so I just wanted to tell people that although we don't really know the exact mechanisms of cardiovascular disease, that there are lots of different mechanisms that are proposed. And we're just studying one of these avenues. And just to highlight one of the findings and groups that we've had that showed the clinical findings, along with the basic science models that we're finding. And so with this, it's a case not unusual for many of our clients in our long COVID care clinic. A 57-year-old who is a former healthcare worker, has hypertension, dyslipidemia, a well-controlled type 2 diabetes, who actually presented to our long COVID clinic on May of 2023. She had a lot of the symptoms that Dr. Shu was mentioning: fatigue syndromes, brain fog, chronic headaches, dysautonomia, having POTS, was actually evaluated by cardiology and was found to have POTS, but did not benefit from IV infusion of saline. She has chronic cough, and it's unclear, as she had a normal PFTs, but still very mild restrictive lung defect, but still wasn't getting better despite inhalers as well as exercise. She had some gait disturbances. You could see some ENT and menstrual issues, and then overall was depressed, as overall she was not able to go back to her prior work as a healthcare provider. Next slide. And the next slide just basically summarizes. Oh, could you go to the next slide? Oh, the next slide basically just showed the evaluations we've had from PFTs. The chest CT did not show any fibrosis. Echo was normal. MRI showed also no abnormalities. And cardiology, 14-day Holter was unremarkable. The POTS clinic, which is now closed, diagnosed her with having POTS, although she didn't have a formal tilt test. She didn't have any obvious inflammatory markers that showed hyperinflammation, and you could see that she had a borderline ANA, but all the other inflammatory markers were all within normal. So next slide. And so we've tried a variety of things on her, from guanfacine to memantine, modafinil, cromolyn, rapamycin just to see, and also saline infusions. And she has taken salt tabs, but have had some indigestion, have difficulty with that. So her current medication is that of droxidopa, low dose naltrexone. We went through a trial of valganciclovir to try to see if we could maybe reduce some of the viruses, the viral burden from herpes infections. We have her on tenazidine to try to help with some benefits for her muscle pain. And then you could see she's been on Allegra on the antihistamine trials, as well as some of the nasal sprays and other antihypertensive and diabetic medications. So I didn't know if, for the next slide, for Dr. Hsu, what would be the next, this is a presentation that I think you may see in your own clinic. Do you have any other suggestions, that other additional tests that we haven't already performed, and what interventions can be done to try to help improve her functionality? She's pretty much homebound. She does do walks every day, but she's trying to get some improvements in her overall quality of life.
Yeah, no, I think this is it's a great case. And I think more challenging because I would say it doesn't neatly fall into long COVID per se, namely because of her risk factors for cardiovascular disease, at least from my cardiology lens. So I think you touched on a lot of symptoms that are suggestive that there is an element of long COVID, particularly the cognitive symptoms, the fatigue and post-exertional malaise. But things that stood out to me initially, and I think things that I believe are very important are if there's evidence or a concern for cardiovascular disease, I think that needs to be thoroughly evaluated first. I love how the CT, it was noted that there were the coronary calcifications. I always like to check to see if there's been any chest CT imaging to see if there's calcifications. And given older age a bit, and but also a history of hypertension and type 2 diabetes and dyslipidemia, so a lot of risk factors for disease, and the presence of the calcification shows that there is coronary disease there. So I do want to make sure that at least her exertional symptoms, her exercise intolerance, I want to make sure that there's no clear evidence that there's any ischemic component to it. So I'm not sure if this was done. I don't remember seeing it, but at least some type of stress test, some ischemic testing to objectively rule out the presence of that. So I think that would be helpful. What we would do in our program usually is I do a lot of cardiopulmonary exercise testing, CPAT. So I think that's something that could be helpful because can not only look at the cardiac issues, but also try to identify some pulmonary issues contributing to exercise intolerance. So I think that would be a test that would be helpful and at least important to rule that out. If that's ruled out, then I would also want to more specifically characterize the POTS diagnosis. So one thing I look for on the active stand test or the tilt table test is not only the heart rate response, but also the blood pressure response. I mentioned before that we're looking for the drop to see if there's orthostatic hypotension. I think she may have had that. So I think that gets challenging when we try to, in order to treat that, especially if someone has a history of hypertension. So I'd be curious just to know what her blood pressure ranges are, if they generally run on the lower side or higher side, and that'll impact the types of agents that we can use to help with their orthostatic symptoms. And notably, she's on droxidopa, which I'll say I don't typically start myself. I've seen a few patients on it, but if I'm seeing that on their list, and it's clear, usually they're pretty advanced and been like pretty hard to treat. But typically for orthostatic hypotension in me, I'm using medications like fludrocortisone and midodrine. Can be challenging though, because again, she has a hypertension history, and it may feel weird to give midodrine to someone who has underlying hypertension. So this would all depend on just what her home BPs have been. If she's running high, then I'm a little bit more concerned about using like midodrine in that. One thing to note too is not in her case, but in patients where I do see a hypertensive response to standing, and I see that pressures are generally higher, but they have orthostatic intolerance and POTS-like physiology. This is where I bring in medications like clonidine. I noticed guanfacine was a medication she tried. So guanfacine and clonidine are like cousins, same class. I like clonidine because it's available in a patch form. You can use it as a 0.1 milligram per week patch. You just put it on every week and exchange it every week. But I feel like when they have these, something that suggests that they have these surges of catecholamines that raise their blood pressure, they often will say that they have surges, bursts of symptoms, like even symptoms that wake them up at night. I tend to find clonidine helps to kind of curb these surges. And then I used to always hate clonidine use as a cardiologist before this, but this is kind of the only population nowadays where I use clonidine more regularly. But if they, in her case, I get worried about using clonidine though if their blood pressures are running low already, and I think that may limit the ability to use it in her, unfortunately. But yeah, I'd say. It's good that she's tried the IV fluids. I'd be, really keen on just making sure that she's still drinking a lot of fluids herself, several liters a day. Sodium consumption is a little bit trickier when they have hypertension too. So I'm not as aggressive with sodium when they have underlying hypertension. I think, if she's on antihypertensive meds too, I didn't see what they were exactly. I think something very commonly we see in our clinic is that there's so many meds that are tried, but then they end up with this massive med list. And I think sometimes it's important just to take the time to just see are we shooting ourselves in the foot with some of the meds that were prescribed a long time ago that are still on, and maybe counteracting some of the newer meds that we're trying to. So if she's on antihypertensive meds, but she's having orthostatic hypotension, maybe we can drop some of the hypertension meds and see if that helps with those symptoms. So yeah, so kind of some thoughts I have on her case.
No, thank you so much. Yeah, I think she typically runs higher, and so that clonidine idea, yeah, thank you for some of the great suggestions, and the additional imaging cardiac testing would be helpful.
Yeah.
I know we kind of went through time. Melissa, do we have questions out for any one of us?
So I'm looking in the chat right now, and so I don't see any questions and I don't see any hand raised. So since we're at the end of the hour, unless I see something here real quick, I just want to thank everybody for coming. Special thank you. Oh, go ahead.
Oh, I just wanted also, after Melissa's presentation too with the research, I think it's really, really exciting research that's being done. I think clearly the holy grail in this field is identifying a biomarker for long COVID. So really good to see that you're looking into it. And I think these are exciting early results, particularly for, the ACE2 autoantibody. It just seems like a syndrome where autoantibodies are at play. We just haven't really identified which one it is. And our general autoantibody panels don't capture everything. And maybe we're dealing with kind of a unique one here, but really great. And thanks for sharing that research.
Thank you.
All right, so thank you everybody for joining, and a special thank you to our presenters for today. If you're interested, our next session is on August 26th, and it's going to be covering pulmonary complications in long COVID. So we look forward to seeing you then. Thanks again.